Right. Hello, everyone. Welcome to this exciting session on spinal endoscopy with BritSpine. I will invite Sachin to actually start off the whole session, to introduce the speakers and to actually tell you a little bit of a background as to how this session came about being. Thank you, Sachin.
Great. Thanks, Biren. I won't take too long. All I would like to do firstly is thank a few people. So firstly, thanks to Mike Grevitt, who set this ball rolling for us for this collaboration with BASS and NASS. Looks like I'll break into a song, but I won't. So I thought it will be a good opportunity for the two societies to collaborate and work together. Mike introduced us to Charlie. Charlie's been absolutely pivotal and fantastic in trying to set this up for us. Thank you, Charlie, very much, along with Michael Piccarello and the rest of the team that Charlie's put together. I know what's coming, and I know it's absolutely fascinating. So I'll hand over to Biren and Michael to take over this session. Thank you very much again, and look forward to more collaborations in the future.
Thanks a lot, Sachin. So we start off this session. We have a series of exciting talks from experts in different parts of the countries. So we start off with Dr. Yusuf on how to get started in endoscopy. Dr. Yusuf's talk.
Just bear with me, the labels on the talks haven't come through very clearly, so I'll just try and make sure we've got the right one.
Okay.
Hi, my name is Christoph Afsala.
Thought as much.
Definitely
No.
So I've been tasked with talking about fusion as a problem.
Typical. Sorry.
Ladies and gentlemen, greetings from Egypt. This is Magdi Youssef, the head of the spine unit at Ain Shams University Hospitals. And thank you very much for inviting me to this big event. Starting your spine endoscopy journey. By the end of my lecture, you will be able to value the advantages, the principles, the key steps, and the key challenges to starting spine endoscopy. Spine endoscopy is not just a small opening to see the other end of your patient's back. It's a different view aiming the same target. Why endoscopy? Evidence shows increasing popularity and excellent results. It's the least invasive percutaneous surgery with the least collateral damage. It preserves stabilizing structures with the least possible bleeding. It is done under local anesthesia as a day case surgery with minimal morbidity curve. Less infection rates, direct targeting of the pathology, real-time pain relief. It allows sealing of the leaking annulus with wide indications like discectomies, stenosis, and foraminoplasties. The challenges are simply due to the different anatomy, the different orientation, the different visualization, the different tools used, and the different manipulation. The key for success in these cases is the attention of details. Attention to details in every aspect. You have to be aware of endoscopic anatomy, the use of endoscope, the use of fluoroscopy, the correct positioning of the patient, the OR settings, the preoperative planning, the radiological analysis, the correct placement of the needles, playing safely with the instruments, choosing the proper technique, and then managing the problems. The best to be a trained spine surgeon, not only because it gives you the confidence and ability to manage the problems in the short and long term, but it also helps you to appreciate the difficulties of open surgery and to realize the potential of endoscopic approaches. A basic knowledge is mandatory. You have to read books and articles, you have to see videos and attend online courses. Then go for practical exercise to see the technique in workshops, in cadaveric courses, in fellowships, attend cases with endoscopic spine surgeons, and expose yourself to different schools of endoscopic surgery. A mentor or mentors is the most important thing. This is mandatory. You have to have a mentor. This is Dr. Sukumar. This is Dr. Mahisha from India. This is Dr. Saeed Osman from USA. Respect the experience. You will see some endoscopic surgeons finishing a case in 5 minutes. Only then you have to appreciate that they have done thousands of cases over years, and you have to follow them to reach this level. Then start building your own skills by bridging the learning curve. It's a long one. It's not only you, it's the whole team. the X-ray technicians, the nurses, the assistants, the anesthetists, and decision-making is part of these skills. Don't rush. You will reach your own way. You will reach your own tips and tricks. Let us cross some virtual barriers. As spine surgeons, we are all used to approach the disc from the top. And this is what we see in regular surgery. Lamina, spinous processes, ligamentum flavum, we cut the ligamentum flavum, we retract the root, and we reach the disc, which is okay. But in endoscopic surgery, it is different. For example, in transfemoral cases, we approach the disc from below. So we go in from where the root leaves. And this is what we see in open surgery. We reach the top or the tip of the fragment. In transfemoral cases, we go at the base of the fragment. And this is what we call targeted fragmentectomy. This is the safe zone. This is the traversing route, and this is the exiting route. And this safe zone is the exact point or the exact docking site of your scope to start the surgery. Simply, you use a natural opening in the spinal canal, which is the neural foramen, to put the scope here to reach the spinal canal and do the surgery. It's a completely different view. This is the cadaveric view showing this is the open surgery, the regular surgery. This is the dura and the root. But you can see here the cannula of the transfemoral surgery going through the foramen, giving you a different view to the spinal canal. Change the way you see the spine. This is the challenge. Anatomy is the same, pathology is the same, but the perception is different. The tools are different, and the manipulation is different. If I show you this view, this is the first view you see in transfemoral endoscopic discectomy. For an open surgeon, it's very difficult to realize or orient himself to this. If you look carefully, from 3 o'clock here, bridging the field is the annulus, coming from 3 o'clock to 9 o'clock. And this is the radio frequency probe cleaning the working zone, preparing the annulus to be cut with a cutter. And this is what we call the 50-50 view. At 6 o'clock is the disc side, and 12 o'clock is the dural side, and this is the cutter in. So for an open surgeon, it is really different. You have to have some time to be oriented with this and to manipulate the disc and remove the fragment in this a new way of doing it. So a percutaneous targeted surgery, which is the endoscopic surgery, needs accuracy. You need accurate landmarking. You need accurate landing to reach the proper working zone and start the case. We have either transfemoral or interlaminar approaches, and let us take an example for the transfemoral one. This is the room setup. The patient is lying in the prone position. You and the nurse and the instruments are on the side of the offending disc. Anesthetist is at the head of the patient, the technician at the leg of the patient, and you are facing the X-ray technician. And these are the basic instruments you are going to use: the access tools, the visual tools, disc tools, the bone tools, the nerve tools, and the tissue tools. Then you have the camera, the light source, the shavers, the drill system, the pump, radio frequency, and laser. And these are the access tools. This is the needle, the guide wire, and the dilator. And this is the dilator in place going over the wire to the disc. Then the cannula goes over this dilator, and we have different types of cannulae according to the case. And then the scope goes in. We all know that it gives you the wide field with the best illumination. And I always call it the Egyptian spirit of endoscopy. This is the scope. This is the working channel allowing the instruments to go through. This is the light source. This is the camera and the irrigation channel. And this is the irrigation system. These are some basic disc tools. These are the disc punches. And this is the annular cutters. Some bent instruments for special cases. Bone tools. We have burrs. We have articulating burrs. We have caissons. We have also some shavers to use in foraminoplasty cases. Different types of root retractors. And then the radio frequency, which is the safest method for tissue modulation with the minimum heat transmission. And then the laser, which can be able to cut, coagulate, shrink, and vaporize the tissues. And then how to do it. The steps are the proper markings, proper needle placement, then the cannula and the scope. Then you start. This is the local anesthesia at the site of the entry of the needle. The needle placement is the key for success here. Under AP and lateral control with the C-arm, you have to put it in the proper position. Once you are inside, then you go with the guide wire. Then the guide wire is in the proper position. Follow this with the dilator, and then remove the wire and proceed with the sheath or the cannula, then put your scope and start your surgery. Even with interlaminar endoscopy, it needs time to train yourself to hold the cannula, the scope, and play with them by one hand, and then you work through the scope by the other hand needs training also. So is it worth starting? Yes, definitely. You have to start. It's a safe, precise, innovative, novel enabling technique. It's my advice to learn open surgery. You have to be a trained spine surgeon to back yourself, to open if you want, to manage your complications if it happens. You have to study the basics of endoscopic anatomy and watch a lot of videos to orient yourself, attend a lot of courses, attend hands-on workshops, see many cases, have a mentor, which is very important, do many injections like discograms and facet blocks to orient yourself, to have the sense how to manipulate the needle inside, choose your cases properly, start by a simple case like L4-5 transforamen with a wide foramen, or L5S1 interlaminar with a wide interlaminar window. Operate regularly, don't stop. If you stop, you have to start from the beginning. Watch your surgeries and do MRI post-operative. This will help you to correct yourself and to manage your mistakes for the next cases. Remember that safety comes first. So knowledge is being aware of what you can do. With time, as you do a lot of cases, then wisdom is knowing when not to do it. Thank you very much for your attention, and I'm ready for your questions. Thank you.
Many thanks for a fantastic introduction. I'd be grateful if all the attendees, if they have any questions, if they put it in the chat box. And our plan is to have a question and answer session after the first 4 talks before we move on to more controversial topics. So I have great pleasure in inviting Dr. Gibson, our own Dr. Gibson from Edinburgh. He has a wealth of experience, so he's the best person to talk to you about advantages of different approaches for spine endoscopy.
Everyone, in this talk, we're going to look at the advantages of different approaches to the spine with particular relevance to endoscopy. We live in uncertain times, and the one thing that the COVID-19 pandemic has led to is a review of our surgical practices. Endoscopy diminishes the need for direct patient contact, both from the anaesthetist if analogous sedation is used, and also from the operating surgeon. We're able to keep a safe distance, and irrigation probably dilutes the virus present in and around the operating area. Common practice in endoscopy really started after Parvis Cambin's description of the safe triangle. And initial studies were of endoscopic tesis with microdiscectomy. From our own trial in Edinburgh, which was a randomized trial showing good or equivalent patient outcomes, shorter length of hospital stay, and perhaps most interestingly, a reduction in leg pain at 2 years with endoscopy over microdiscectomy. Perhaps most importantly, we found that tesis was cost effective. And these results have been replicated in other randomized trials, which generally show no significant differences in outcomes and complications, but a reduced patient insult and better and faster patient recovery. Transforaminal approaches are generally applicable to all pathologies within the spine, even at the lumbosacral junction, particularly if the patient is placed in the lateral position in the operating table, which allows opening up of the foramen, and I recommend this to you. Perhaps when a surgeon starts out, he should avoid, in these first cases, those with a high iliac crest, upward herniated prolapses, old calcified discs, bony stenosis, and patients with a transitional vertebra. Modifications to the standard approach may help, and the transpedicular access is now well described for inferiorly migrated herniations. Don't forget foraminotomy. Old patients don't do well from general anesthesia. And anything that can be done to reduce the insult to the old patients is clearly advantageous. We know that massive correction of degenerative scoliosis is associated with a high incidence of complications, reoperations, and risk of secondary surgery. And why would they want to undergo such an invasive procedure if the patient is only complaining of isolated root pain anyway? We now have excellent reamers, burrs, and other instruments to widen out the foramen. And by doing so, we might be able to relieve the patient's leg pain and allow them to return to normal activities very rapidly.
By the end of my lecture, you will be able to value the advantages, the principles,
Endoscopy,
the key steps, and the key challenges to
is
starting
also
spine
extremely
endoscopy.
valuable for
Spine endoscopy is not just a small
cysts,
opening to see the
which
other end of
actually
your
don't do
patient's back.
particularly well from open surgery.
It's a different view,
And their
aiming the
results
same
show
target.
good outcomes.
Why endoscopy?
Albeit in a very
Evidence
small
shows
series,
increasing popularity and
from
excellent
sepsis
results. It's the
resection.
least invasive percutaneous surgery with the least collateral damage. It preserves stabilizing structures
Interlaminar approaches
with the
also
least
have their
possible
place.
bleeding. It is done under
And
local anesthesia as a day case surgery
The,
with minimal morbidity curve. Less infection
they're
rates,
useful
direct
for
targeting of the
if
pathology,
translaminar
real-time pain
approaches are
relief.
limited.
It allows sealing of the leaking
deformity,
annulus with wide indications like discectomies, stenosis, and
dorsal stenosis of the
foraminoplasties.
canal.
The challenges
and
are simply due to the
this
different
prolapse
anatomy,
was
the
sequestered
different
dorsal to the
orientation,
fecal
the
sac.
different visualization, the different tools used, and the
They
different
also
manipulation.
allow us to
The key for success
expose
in
the
these
spine
cases is the attention
for
to details.
standard decompression,
Attention to details in every
avoiding
aspect. You have to be aware of endoscopic anatomy,
laminotomies,
the use of endoscope,
laminectomy,
the use of fluoroscopy, the correct
and
positioning of the patient,
from a
the OR
unilateral
settings, the
approach, we
preoperative
can now
planning, the
undertake
radiological
bilateral
analysis, the
decompression.
correct placement of the needles,
And I think we're going to
playing
discuss
safely
this
with the
later
instruments,
in this series
choosing
of
the
talks.
proper technique, and then managing the
Translaminar
problems.
access can also be useful.
The best to be a trained spine
Upward
surgeon, not
migrated
only because it
discs.
gives you the confidence and ability to manage the problems in the short and long term, but it also helps you to appreciate the
Turning to the
difficulties of open
cervical
surgery
spine,
and to realize the
we recently
potential
published a
of
review
endoscopic approaches.
of a number
A
of
basic
articles
knowledge is mandatory.
in
You have to
relation
read
to
books and
anterior
articles. You
cervical
have to see
endoscopy.
videos and attend online courses. Then go for practical exercise to see the technique in workshops, in cadaveric courses, in fellowships, attend cases with endoscopic spine surgeons, and expose yourself to different
And the
schools of
numbers
endoscopic surgery.
increase year on year.
A mentor or
110
mentors is the
articles
most
only
important
last
thing.
year.
This is mandatory. You have
The
to have a
results of
mentor.
our meta-analysis
This is Dr.
showed that
Sukumar.
excellent and good
This is
results
Dr.
could
Mahisha
be
from India.
produced in
This is Dr.
90%
Saeed Osman
of
from USA.
instances, with a very low rate of complications.
Respect to the
and reduced
experience, you will
surgery.
see some endoscopic surgeons
Outcomes
finishing a
were
case in 5
equivalent
minutes.
or possibly
Only
better
then you
than
have to
those
appreciate
obtained
that they have
from
done
ACDF
thousands of cases over
and
years,
cervical disc
and you have to
replacement.
follow them to reach this level. Then start
Certainly,
building
the
your own
patient's
skills
recovery
by
is
bridging
much more
the
rapid
learning
from an
curve.
anterior cervical
It's a long one.
discectomy by
It's
an
not only
endoscopic
you, it's the
approach
whole team.
than from,
The X-ray technicians,
more
the nurses,
invasive
the assistants, the
surgery.
anesthetists. And decision-making is part of these skills.
And the same really applies
Don't
to
rush.
posterior
You will
cervical
reach your own
foraminotomy,
way. You will reach
where
your
we
own
found
tips and
excellent
tricks.
results in
Let us cross some virtual
2,000
barriers.
or so patients.
As a spine surgeons, we are all used to approach the risk from the top. And this is what we see in regular surgery.
And the success rate,
spinous processes, ligament of
complication rate,
flavum,
and
we cut the
reoperation
ligament of
rate that
flavum,
you
we retract
reported
the root, and we
was
reach the
almost
disc,
identical
which is okay.
to that
But in
from other
endoscopic
minimally
surgery,
invasive
it's
approaches,
different.
such as with
For
tubular
example, in transfemoral cases, we
devices.
approach the disc from below. So we
and we
go
know
in from where the
that
root
with
is.
endoscopy,
And
as shown
this
in
is
the
what we see
slides
in
on the
open
right,
surgery.
you
We
get an
reach the top or the
excellent
tip of
view
the fragment.
of the
In
external
transfemoral
root
cases, we go at the base of the
and
fragment.
surrounding
And this is what
structures.
we call targeted fragmentectomy. This is the
So when
safe
should we
zone.
use an
This is
anterior
the
or posterior
traversing route,
approach
and
in
this
the
is
neck?
the exiting route.
Well, the
And this
anterior
safe
approach
zone
is very
is the
useful
exact
for soft disc
point
prolapses,
or the exact
and if
docking
the
site of your
compression on
scope
the
to
nerve
start
root
the
is
surgery.
anterior. The reverse
Simply,
is
you
probably
use a
true for
natural opening
posterior
in the spinal
approaches,
canal, which is the
posterior
neural foramen.
foraminal osteophytes, and actually multi-level disease is easily and adequately treated by posterior cervical foraminotomy. Recently, I published results from thoracic endoscopy with a review of the literature. We found 17 patient series, 1 cohort study, and 13 case reports. And an excellent and good outcome was reported in 81% of patients with a very low rate of complications. This compares with the fairly high rate of complications that one would expect after thoracotomy, after lateral extracavitary approaches, and costrotransversectomy. So in summary, full endoscopic
To put the scope here, to reach the spinal canal and do the surgery, it's a completely different view.
Equal or exceed those.
This is the cadaveric view showing this is the open surgery, the regular surgery.
Probably
here, this is the dura and the root. But you can see here the cannula of the transforaminal surgery going through the foramen, giving you a different view of the spinal canal.
Will allow our teaching program
change the way you see the spine. This is the challenge. Anatomy is the same, pathology is the same, but the perception is different. The tools are different, and the manipulation is different.
Thank you for a fantastic talk.
If I show you this
again, just
view,
a reminder
this is the
to
first
everybody,
view you see in transforaminal endoscopic
we'll discuss
discectomy.
after another couple of talks.
For an
So
open
just put it in the
surgeon,
chat
it's
show.
very difficult to realize.
We move on to the next
orient
talk by
himself
Dr. Kim
to this.
on the nuances.
If you look carefully,
indications
from 3 o'clock here,
for
bridging
endoscopic spine surgery.
the field is the annulus, coming from
Hello,
3 o'clock to 9
everybody.
o'clock.
It's my
And
honor
this is the
to have
radio
a
frequency probe cleaning the working zone, preparing the annulus to be cut with a cutter. And this is what we call the 50-50 view. At 6 o'clock
So we
is the
move
disc
on to
side,
the next talk.
and 12 o'clock is the dural side, and this is the cutter in. So for an open surgeon, it is really different. You have to have some time to be oriented with this and to manipulate the disc and remove the fragment in this a new way of doing it. So a percutaneous targeted surgery, which is the endoscopic surgery, needs accuracy. You need accurate landmarking. You need accurate landing to reach the proper working zone and start the case. We have either transforaminal or interlaminar approaches, and let us take an example for the transforaminal one. This is the room setup. The patient is lying in the prone position. You and the nurse and the instruments are on the side of the offending disc. Anesthetist is at the head of the patient, the technician at the leg of the patient, and you are facing the X-ray technician. And these are the basic instruments you are going to use: the access tools, the visual tools, disc tools, the bone tools, the nerve tools, and the tissue tools. Then you have the camera, the light source, the shavers, the drill system, the pump, radio frequency, and laser. And these are the access tools. This is the needle, the guide wire, and the dilator.
chance to present
And this is the dilator
this topic,
in place
nuance of
going
the
over the
indication of
wire to the
endoscopic
disc.
spine surgery.
Then the
I am
cannula goes
Professor
over this
Kim,
dilator, and we have
practicing
different
Seoul
types of
Saint Mary Hospital
cannuling
in
according to
Korea.
the case.
This is my
And then the
disclosure.
scope goes in.
Actually, the
We all know that it gives you the
indication
wide
and the
field with the
contraindication,
best illumination. And I always call it the Egyptian spirit of endoscopy. This is the scope. This is the working channel allowing the instruments to go through. This is the light source. This is the camera and the irrigation channel. And this is the irrigation system. These are some basic disc tools. These are the disc punches. And this is the annular cutters. Some bent instruments for special cases. Bone tools. We have burrs. We have articulating burrs. We have caissons. We have also some shavers to use in foraminoplasty cases. Different types of root retractors. And then the radio frequency, which is the safest method for tissue modulation with the minimum heat transmission. And then the laser, which can be able to cut, coagulate, shrink, and vaporize the tissues. And then how to do it. The steps are the proper markings, proper needle placement, then the cannula and the scope. Then you start. This is the local anesthesia at the site of the entry of the needle. The needle placement is the key for success here. Under AP and lateral control with the C-arm, you have to put it in the proper position. Once you are inside, then you go with the guide wire.
Limitation.
Then the
It
guide wire is
has
in the proper
been
position.
constantly
Follow this with
changed
the
over
dilator.
time. In the
And
past,
then
we
remove the
just
wire
treat the
and proceed with
contained
the sheath of the
disconnection
cannula.
by
Then put your scope
simple
and start your
targeting
surgery.
through the Campbell triangle.
Even with
presently,
interlaminar
we are
endoscopy, it
able to
needs
treat
time
the
to train
most of
yourself
the
to
herniated
hold the
disc and
cannula,
the
the scope,
central
and
stenosis
play
and
with them
foraminal
by one
stenosis,
hand, and
but
then
we
you
still
walk through
have
the scope
some
by the other hand needs
questions
training
of
also.
effectiveness of spinal endoscope
So, is
for
it
the
worth
treatment of
starting?
severe
Yes,
spinal
definitely. You
stenosis
have to start. It's a
and the
safe, precise,
kinematic fusion.
innovative, noble,
That's why
enabling technique.
some of the trailblazer
It's my
developed
advice to
and
learn open
expanded
surgery. You
the
have to be a trained
bipolar
spine
endoscopic
surgery
surgery.
surgeon
So
to
I
back
believe
yourself,
the
to
most of
open
the
if you want, to
MI's
manage your complications
decompression
if it
could
happens.
be
You have to
replaced
study the
by the
basics of
endoscope.
endoscopic
In
anatomy
limited cases,
and
number
watch a
of the
lot of videos to
fusion
orient yourself.
can be
Attend a lot of
available
courses,
also
attend hands-on
by
workshops, see many
endoscope
cases,
fusion,
have a mentor,
etc.
which is very important.
So Michael
Do many
Meyer
injections
already
like
noted
discograms
most
and
of
facet
the
blocks to
microscope
orient
surgery
yourself,
could be
to have
replaced
the sense
by the
how
endoscope
to manipulate
with
the needle
step
inside.
by step. Let's
Choose
see
your cases
the key
properly.
opinion
Start by
readers.
a simple
Jeffrey
case like
Wang,
L4-5
he noted
transforamen with a
it
wide
appears
foramen, or L5S1 interlaminar with a wide interlaminar window. Operate regularly. Don't stop.
that
If
the
you
entrance
stop,
of
you have
spinal
to start
endoscope
from the
into the
beginning.
mainstream
Watch your
arena
surgeries
of spinal
and do
surgery
MRI postoperative.
inevitable.
This will help
Recently,
you
we
to correct
have the
yourself
most
and to
impactful
manage your
paper.
mistakes for the next
By
cases.
this paper, they
Remember that
concluded,
safety comes first.
compared
So
with the
knowledge is
open
being
or
aware of what you
microscopic
can do.
discectomy,
With time,
result
as you
of
do
this
a lot of
meta-analysis
cases, then
suggests that
wisdom is
transfer
knowing when not to
endoscopy
do it.
has a low risk of overall
Thank you very much for your
complication. I
attention,
also
and I'm ready for your
published the
questions. Thank you.
cost-effectiveness paper of microdiscectomy versus endoscopy for lumbar disc herniation. We compared the full surgical common surgical procedure for discectomy right there. So conclusion, transfer endoscopy is more cost-effective compared to the microdiscectomy. I'm gonna move on the cases. This female, 79 years old female patient, have the high grade, the cuffs angle more than nearly 60 degree, and patient just have monoradiculopathy, left side, an MRI and CT scan. I'd like to find a real pain generator in this patient. Obviously, there is a foraminal stenosis and radialis stenosis at the 3-4 left side. For endoscopic surgery, we need to highlight find the real pain generator that is a target-oriented spinal surgery. If you consider diffusion surgery in this patient, what kind of complication may happen? Like this, treat this patient using the endoscopic with the navigation guided because of a complexity in this patient. Under the prone position, attach reference frame on the patient back, find the trajectory using the navigation, and introduce walking cannula right there, and put the obturator and introduce the navigation guided endoscope. So once we find the ideal trajectory and the targeting, we can go with the endoscopic foraminotomy and endoscopic discectomy. Because of time limited, I'm gonna show you guys the end of the compression status, radialis, and the foramen as well. This is patient outcome. Sorry for converted the video clip. There's a well decompression of the foramen in this patient, and I follow this patient more than 6 months. Fortunately, patient didn't have any aggravation of the cuffs angle. So let's move on. The other indication of the endoscope is role in malignant. I mean, it's only the limited in the specific cases like this. Patient have acute onset progressive leg weakness, post leg foot drop. You can find the canal occupying the mass, not only spinal canal on the retroperitoneum. patient have underlying have the CML and follicular lymphoma. So this is how I made the decompression. You can see the pre-op status having the both leg weakness. Patient have the pre-op weakness ankle, dorsiflexion, and plantar flexion weakness. And also weakness on the knee extension as well. And let's see the post-op improvement of the leg. So endoscope has also could be adopted in cervical myelopathy. This is junctional problem following the ACDF at the C3-4 level. Patient have acute onset quadriparesis. By the endoscopic decompression, you can see the well pulsating the cervical cord, right? So what about the other endoscopic spinal surgery? Special case with the huge hemorrhagic vasculitis at cervicothoracic junction level. Because the cervicothoracic junction it is hard to identify the exact level. So in most cases, if you want to do the decompression, you need to wide open to see the location. The endoscope, that is why the endoscope may need the help navigation. It is truly important tool to find the exact targeting and location.
Another fantastic talk.
This is
Shows you the whole
another
breadth
interesting
of
case.
pathologies
Once
that
the
can be
corpectomy
dealt
achieved,
with using
there's a
endoscopy.
remnant bony fragment
I would like to invite a
there.
talk by Dr. Hofstetter on the
So
nuances
this kind of
the
remnant
post-section
bony
of things.
could be removed by the
neurosurgeon at the
endoscope.
University of Washington. I would like to thank the organizers of BritSpine to include me in this meeting. We've heard fantastic
So in
talks
summary,
regarding endoscopic spine
there's a
surgery,
benefit of
endoscopectomies, and
MIS.
fusion
This
surgeries.
is very
And I would
awesome
like to
cartridge
talk
by
about the
Roger Hartle
nuances of
in Cornell
approach selection
University.
when
I
targeting the lateral
revise
recess.
this
Here are my disclosures. First, I want to talk
of
about the
MIS
anatomy
to
of
the
the lateral
endoscopic
recess. The
spine
lateral
surgery.
recess is defined dorsally by
Interestingly,
the
there
facet
is a
joint covered by your
unmet
ligament, ventrally by the
gap
annulus of
between the
the
open
disc.
traditional
Typically
surgery
at 4,
with
5,
the
and
endoscopic
5, 1
spine
in the
surgery.
lateral
I
recess, we
think
find the
that's
traversing
going to be
nerve root.
the
Here's an inside view,
special
contralateral inside view
benefits
of the lateral recess. Dorsal
of the
is here the
endoscope.
facet joint covered with yellow
So
ligament.
current
Traversing nerve root
status
is indicated
endoscope based
by
on
the
the
arrow.
academic level.
And the lateral recess
It is
height actually
approaching the
decreases significantly at
standard
L5. L1 is 9 millimeters and
treatment,
L4
very
typically
close
6
status.
millimeters. And
When
for
you
that
think
reason, it's
about
not
the
surprising
history
that
and the
most
future,
commonly the
it
lateral
is not
recess
big issue already.
is
So
symptomatic at
endoscope can
L4,
treat
5,
the
and 5, 1.
electrolysis. Endoscope can treat the spinal
One little
decompression,
pearl here is
myelopathy.
in
I
particular
think that's
looking
going
at
to be
peripheral
problem
imaging,
of time
looking at the
consuming.
angles of the lateral recess
Eventually,
can
it'll
be
be done.
useful.
Right.
And so especially at this
So
angle
we have
of the lateral
those kind
recess
of
centered on top of
history
the nerve root
from
is less
the
than 20 degrees,
pre-branding
or
status,
the
setup
height of the lateral
status,
recess is less than
and
3 centimeters, 3
hypermaturation
millimeters.
status. That is the expansion of the
Compression of the
category.
traversing nerve root
And
can be
now
suspected here.
we are stand on
What are the
the
techniques to get there?
late
So well, we have the
stage
interlaminar
of
technique of the lateral
hypersegmentation.
recess, we call it
There are a lot of
IEL,
the spine surgeons in Asia and recently
L4,
the
5, and 5,
States
1.
and the Latin America. They
One little
have
pearl here
learned,
is
tried
in
tons
particular
of
looking
endoscopic
at
spine
peripheral
surgery.
imaging, looking
So
at the angles of the lateral
next
recess can be
time we're
useful.
gonna
And so especially at this angle
face the
of
golden
the lateral
age
recess
of
centered on
endoscopic
top of the nerve
spine
root is
surgery.
less than 20 degrees,
So
or the
do you want to
height
walk
of the
in the
lateral
golden
recess is
age
less
of
than 3
endoscopic
centimeters, 3 millimeters.
together? Hopefully
Compression of the
you do.
traversing
Thank
nerve
you
root
very
can be
much.
suspected here. What are the techniques to get there? So, well, we have the interlaminar technique of the lateral recess. We call it IELRD. The target area is the inframedial edge of the lamina. The principal anatomical landmark is the laminar attachment of the ligament. It's performed with a laminoscope general characteristics is typically around a little bit more than 4 millimeter working channel. View angle is 15 to 25 degrees. And importantly for this talk is the interlaminar approach allows for a nice rostrocaudal extent and decompression of the lateral recess. Couple of examples of this. So we had, why did we choose this approach in this young female, 39-year-old female, was 9 years status post L4 to S1 TLIF, presented with right-sided thigh and calf pain and EHL weakness. She underwent preoperative imaging, which revealed that she had a spacer which had was displaced posteriorly. You can see an MRI here. This is TLIF spacer. On the X-ray, as on the CT scan, you can see the TLIF spacer compressing the lateral recess. And in this case, we decided to do a interlaminar approach, and the patient had experienced complete remission. Here is an intraoperative image of the traversing nerve root. Once medialized, the cage is nicely seen. It can be drilled down as demonstrated here in the postoperative CT scan. Learning points, the endoscope allows, in particular a small laminoscope, it allows accessing the neural elements in between previously placed instrumentation. This case could also have been done by a transforaminal route, but we felt that the rostrocaudal removal of the spacer was easier done by an interlaminar route. Another example here, 40-year-old female. She's had 3 history of left L5 discectomies. She presented with 6 months of lower extremity posterior thigh and calf pain. Patient also had back pain and was severely disabled. Here's a preoperative image. You can see the osteophyte disc complex in the lateral recess on the CT scan, large osteophytes and signs of multiple previous dorsal decompressions. So this case was done by an interlaminar approach for the following reason. The patient had a high iliac crests. Typically, if the iliac crests are above the mid portion of L4, a transforaminal approach is difficult. And the other thing why we chose an interlaminar approach is we wanted to resect that large disc osteophyte complex ventral to the nerve root. And so learning point here is those osteophyte complexes can be nicely decompressed in interlaminar technique while the nerve root is medialized with the working sleeve. And you can safely remove disc and osteophyte complexes ventral to the traversing nerve root. One last example, so a 71-year-old male, history of a very minimal left L3, L4 medial facetectomy a year ago, presented with recurrent symptoms, pain rated in his left buttocks, lateral thigh, and standing and walking aggravated the pain, and had L5, basically motor weakness with dorsiflexion weakness, left gluteus medius weakness. Here was the preoperative imaging, unclear exactly what type of procedure was done here, very, very minimal. And so for that reason, given that we wanted to explore that area a little bit more in detail, we decided to go for an interlaminar approach in this case. Patient is currently 3 months out. His symptoms resolved, his pain, however, his weakness persisted. So here is if the anatomy is a little bit more unclear, then it can be safely approached. As you can see here, rostral, here caudal neural elements, and it can be nicely approached. And now we see the neural elements, and we can also now strip it off the scar tissue. Here is that scar tissue that we saw on the MRI here right now. And using a dissector, the nerve root is nicely freed up here right now. And so that is easier visualized and more thoroughly depicted on an interlaminar approach. So now let's go to the transforaminal approach. Here we call it TELRD, and it's done with a foraminoscope. Has the main difference is the viewing angle is 25 to 30 degrees. And in contrast here is the reach is farther to the midline. It can also go all the way to the contralateral area. However, the rostrocaudal extent of lateral recess decompression is limited. We recently published a technique for that. We call the trans-SAP technique in 40 patients. The difference to the traditional technique is that the foramen is not blindly entered, but rather a Chamsky needle is docked on the lateral aspect of the SAP. Here's our outcome in those 40 patients. Nice reduction of leg pain, great reduction of the ODI, adverse events, 1 dural tear, and 2 patients required arthrodesis surgery. Here's an example. 55-year-old male with surgical history of a traditional L4-5 discectomy presents with reherniation. He had a left L5 radiculopathy, 7 out of 10, and left gluteus medius weakness. Here are some intraoperative pictures. The pedicle SAP, and here's the disc, right, on the ventral to the traversing nerve root disc, and then following the disc removal. Learning point is a transforaminal approach provides a virgin surgical corridor for revision discectomy into the lateral recess. And one more example, we have here a 74-year-old surgeon, had a history of an L4-5 laminectomy 5 years ago with low extremity pain and L5 distribution. The patient had undergone an L5 diagnostic block. And here we performed a lateral recess decompression via a transforaminal route. And the patient was asymptomatic 6 months out. Learning points here that the transforaminal approach combined with a foraminoplasty, something that we call the trans-SAP approach, allows for very efficient ventral as well as dorsal decompression of the lateral recess, as you can see here on the CT scan. So you can see the ventral decompression, so we can decompress the marginal osteophytes here, decompress the ventral aspect of the SAP and the yellow ligament. Which brings us to the conclusions. Endoscopic surgery allows for decompression of the lateral recess. Interlaminar technique allows for a nice extended rostrocaudal decompression and is preferred in case of unclear pathology, in case of overlying lateral recess stenosis, in case of high iliac crest at L5S1. Transforaminal technique allows to avoid scar tissue if previous traditional surgery has been done. However, for publishing, it remains unclear how much of the function and symptomatic effect is from decompressing the exiting nerve root versus the decompression of the traversing nerve root. For this reason, we typically do diagnostic blocks to clarify that prior to surgery. And there's a lot of development and new tools and knowledge coming that allows us to become better and more proficient at these techniques. Thank you so much. And please feel free to contact me in case you have any questions. Thank you so much for joining.
First question is from Aparaja Golash. Can this technology be used for large thoracic discs? Followed by how easy is it to combine this if you feel that the endoscopy is not enough? So these two questions, perhaps Dr. Kim or Dr. Gibson would be the best people to answer that. Hello, can you hear me?
I can hear you, Biren. Alistair's there. Do you want to repeat? Can you nod if you can hear Alistair? No, I think Alistair's out of the loop somehow.
Okay, so
Dr. Reitman's on the call. Is he?
Yeah, I was hoping to have a Q&A session before we start off with the next part. Dr. Gibson, can you hear me?
I don't think any of them can hear us for some reason.
can I propose we do the next talks and see if we can sort out the
Okay.
sound?
Okay, so we'll move on to the next talks, on to the controversies. We'll do Q's and A's at the end. The first controversial topic that we are discussing today is endoscopy to perform any lumbar decompression, even severe lumbar decompressions, and a talk by Dr. Wagner. Thank you.
Dear colleagues, it's an honor to speak at that BritSpine event. My topic is, can endoscopy be used to perform any lumbar decompression? First of all, in my opinion, most fusion surgeries are not necessary. There's a lot of fusions done without proper indication. The limits of endoscopy is the surgeon, not the technique. And I always ask myself, would I do the same surgery to my family members? I think that's an important question when you plan surgery and you think about the size of the surgery. The problem in spinal surgery actually is instability, deformity, and compression of neurostructures. Of course, the endoscopy helps to decompress the compression of neurostructures, and sometimes we can combine it for instability or deformity surgery. Who taught us and how do we define instability? There's a lot of different opinions about that, and we always have to ask ourselves, is fusion the best approach to that problem? I start with the case. So this is an 81-year-old lady. She has L5 nerve root pain and a weakness, persisting pain after conservative treatment. You see, she has a degenerative lumbar scoliosis, so it's a proper indication for a fusion. So we have an instability, and we also have some neural compression, as we see here at the level of L4-5 on the left side. But the patient doesn't complain about back pain. So her only complaint is L5 nerve root pain. So this was the reason why I performed an interlaminar decompression, and the pre-postoperative pictures actually show that a good decompression could be observed after the surgery, and the patient's pain in the left leg was gone. And without correction of that deformity and major instability, the patient is pain-free. Those are pictures of a second-grade spondylolisthesis, and again, it's an over 80-year-old patient, and you see the lower part of the slides. They show an extensive decompression done by an endoscopic interlaminar approach. This patient did not complain about back pain, but she had bilateral claudication. Then we see this patient. She's a 70-year-old patient, and she underwent actually fusion in the United States in the years of 84. So they performed a Luque instrumentation, and when they took out the implants in Switzerland, they made a big mistake and actually tore the dura, causing an incomplete Corder syndrome. The patient now develops severe pain and bilateral claudication, iliosacral pain, and right-sided leg pain, and we see this facet joint cyst on the right side together with the spinal stenosis. So this is just to show you the amount of decompression I could perform with an interlaminar decompression of this patient without fusion. Of course, she had severe, she was afraid of another surgery, and I think with that picture you see the nicely the traversing nerve root and the decompressed spinal canal. Now we have another patient. She underwent a kyphoplasty at the level of L2, and you see there's bone cement leaking out. The option for that patient would have been to either microsurgically decompress or fuse the patient afterwards with that osteoporotic bone. It might be the beginning of a big problem. And this is an intraoperative picture of a transforaminal decompression. You can see the L2 nerve root completely free.
That's great. And let's go on to the last talk on the endoscopy, future of endoscopy for fusion by Dr. Wang. Thank you.
Proposition for endoscopy. So we've heard some great talks already about how decompression can be done and discectomy can be done by some of the world leaders. But I'm going to make the case that fusion is really where the future of endoscopy will lie. This is my disclosure slide. And let's just start by talking about where endoscopy succeeds. So you can see it in two-tier health systems. You see this sometimes in America where people are doing very specialized patient populations and are trying to track those patients, and they get paid very well to do that. You see it in capital poor systems like in China, where it was expensive to buy operating microscopes and cheaper to buy endoscopes. You can see it in alternative business models. And we see this in America where people own a surgery center, and so they want to attract patients to that and do very small surgeries. And of course, you see it in the select tertiary centers. This is from a paper by Al Telfian and Ralph Wagner, looking at how far people will actually travel to get an endoscopic surgery. And I really got convinced when I went to China and saw the tremendous uptake in endoscopy and how many people were just doing endoscopy, thousands of orthopedic surgeons, and they became very, very good at this because they weren't using any other tools except endoscopy to treat diverse pathologies, right? And this is a plug for a book that Chris Hofstetter and I wrote on, and Chris did almost all the work on this, on the technique of how you can do this, but it's almost all for decompression, right? So let's look at a typical procedure. If you look at a microdiscectomy, for example, you can do it endoscopically or microscopically, right? So both have short hospital stays. Both are low expense procedures. They're cheap. Both can be done in a surgery center. Patient can go home the same day. Both have bad reimbursement. Microscopic is taught more in residency, endoscopic not. But endoscopic has disposable costs. So when you add it up, there's very little incentive for surgeons to learn how to do this when you really, really think about it from that perspective, right? Now, in America, of course, this is not Britain. In America, we have a unique environment, and the value proposition is infusion. Patients who have more complex problems get a fusion. Fusion reimburses better. Surgeons get paid more. The procedure can get more standardized. The fusion is where there's bigger gains in terms of pain control and recovery and cost savings. And of course, you can treat more problems when you can fuse as well as decompress, right? So we got in early on this and we started to do our ERAS awake endoscopic TLIF, and we combined the endoscope with the awake anesthesia, the percutaneous fixation, the long-acting sodium channel blockers, expandable interbodies, and osteobiologics. And this is what it looks like. So people talk about percutaneous fusion, right? But the endoscope adds a lot. You can see on the left, this is the exiting nerve root. You can visualize it, control it so you don't hurt it. On the right, you see the end plate prepared with bleeding bone and the cartilaginous end plate being removed. So you really get a good sense that you're going to get a low non-union rate. And I've published on this. You can read about it. We've done it over 300 cases here at University of Miami. So I'm not going to bore you with too many data points, but this kind of shows you what it looks like. We're doing indicated surgeries. 72% have a spondylolisthesis. These are real pathologies. And when you do that and you fix them anyway, they're going to do very well, right? They're going to get improvement in their ODI, SF36, and EQ5D metrics. This shows you what you can do with it, though. Here's an 86-year-old with an ejection fraction of 11%, and we're going to do that surgery endoscopically because he doesn't have to go through general anesthesia. He loses very little blood, and there's very little tissue disruption, right? And of course, the endoscope is so powerful, it doesn't really matter how big a patient is. You can treat a 400-pounder very easily. You can really get to the business at the business end of the endoscope. But people have questions about, like, how do I get through Campbell's triangle? How do I place and use the endoscope? How do I minimize radiation? And things like getting BMP, right? So we've gone to doing robotics. You know that robotics has taken off in America and around the world. And this is just a sampling of some of the robots that are available in the spine and brain. And we've gone on to do robotic TLIF. So what we do here is instead of doing the wake anesthesia, we simply replace that with the robot, and that lets you get in and guide it in. So actually, you don't really have to be a master of using the fluoroscope to guide your way in to do these procedures to get miniaturization, localization, stabilization, pain control, distraction correction, and arthrodesis, right? But remember, whenever you do these surgeries, the MIS operation has to be measured against the gold standard, which is still an open operation, which is a non-endoscopic operation. We found we have a very low non-union rate. 5 minutes is not enough time to go into all this. I can explain it to you in maybe another meeting, right? Shameless plug for our neurosurgery podcast. Please tune in. And I'm going to stop sharing there. I want to thank you for tuning into BritSpine this year.
Thanks very much. It's a question for Dr. Gibson before we can ask Dr. Reitman to wrap up the session. Dr. Gibson, a lot of people who start doing endoscopy will want to start off with simple cases, but what sort of a learning curve, how many cases do they actually need to do before they start to feel comfortable? And in your practice, what proportion of lumbar degen work is interlaminar as opposed to transforaminal?
I've just spoken to Alistair. He could hear us, but looks like he can. Alistair, can you hear us, please? Alistair? No. Sorry, Brian.
Okay, so maybe we can ask the same question to Dr. Wagner. Dr. Wagner, could you hear the question that I had said before? Would you mind answering that?
Actually.
Okay, so we're having some technical difficulties, so perhaps best to chat outside.
I hope you can hear me. This is Charlie Reitman. We're running short on time, so we'll just wrap this up. quickly. First of all, I just really want to thank the speakers. I think they were really all excellent talks, really showed what I think the future of endoscopy. Certainly these are very skilled surgeons, and clearly there's a learning curve to this and the need for practice, but it really shows you the capabilities. I also want to thank BASS for letting us participate. If there's, I think I've been perusing the chat. There hasn't been a whole lot of questions there. If anybody does have questions, you can probably send them through the chat and get them answered by the specific surgeons. I don't really have anything else. I know we're running a little late and people probably want to get on to other sessions. So Sachin or Byron, if you have any other comments, I think we can wrap it up.
Okay, that's great. Thank you for your comments. I will be in the lobby if anybody else wants to chat, have any questions, answers. Otherwise, we'll finish the session. Thank you very much for a fantastic session.